Okay. It froze, so let me just probably try this. Okay, here we go. Yeah, so first I just wanted to introduce to the audience just a brief description of each institution so we get to know each other a little better. So first I want to start with ICESI. So ICESI is located in Cali, Colombia. It's a high quality institution that got accredited since 2010 by the Colombian National Ministry of Education. And in terms of its med school program, has 23 medical surgical specialty training specialties. It has, according to the website, more than 900 international destinations to its students. This is not medicine, but overall, and 119 bilateral academic cooperation activities. It is important to say, in what is pertinent to us, that their students, their medical students, do their rotations at Hospital Universitario Fundación Valle del Lili, which is the #1 medical institution in Colombia and one of the best hospitals in Latin America. In terms of infectious diseases, which this is all about, they do have, a nice diversity of cases, including vector-borne and tropical illnesses, multi-drug resistant organisms, tuberculosis, transplant infectious diseases, etc. How about Albert Einstein? So Albert Einstein is located in the Bronx, New York, and is one of the largest medicine programs in the United States. As you can see, 714 medical students, more than 2,000 faculty, 221 PhD students, without counting the combined medical PhD program. So it is recognized for its bench to bedside research, and every year it gets funding from the NIH for more than $200 million. And what is kind of new, and that probably people have heard about it internationally and nationally, is that starting this year, students pay $0 for tuition, and this is thanks to a generous contribution from one of the donors. So as I mentioned, the so Montefiore Medical Center is the affiliated like medical group, and so we do have 3 academic sites where our students, residents, and fellows rotate, and in total 13 hospitals that are affiliated to Montefiore across New York City, Westchester County, and Hudson Valley. Our division is about 50 plus faculty members. Every year we get 5 adult ID fellows. And we have a very structured program that has HIV medicine, transplant infectious diseases, antimicrobial stewardship, infection control, etc. So I'm just going to give you a little background of the project. So basically, this all started as a very informal conversation, and Henrik had a lot to do about this. During our infectious disease, rounds on patients, we started talking about how we can integrate, Latin America with the Bronx. And then I can tell that the Bronx has a 57% Hispanic Latino background population, and 34 of them are foreign born. We face different challenges like poverty, high unemployment, unmet social needs. And on top of that, so the Bronx is an area where there's a shortage of physicians that match what patients want. And we think that having culturally competent providers is crucial. So we think that recruiting international trainees can help, although they face a lot of obstacles. For instance, lack of mentorship. The residency application to the United States is a lengthy process. It is expensive. So we thought that maybe doing online learning to begin with will offer new opportunities to connect mentors and mentees internationally. So with that in mind, then we thought that we should create this project. So this is more about what I was just mentioning. So we know that acceptance and adjustment to residency in the U.S. is a big challenge for international medical graduates, to the point that more than 40% of them don't match in internal medicine, not to mention other specialties. So we think it's a lost opportunity, not only for the applicants, but also for academic programs in the United States and the U.S. Healthcare system as a whole. There is a growing need for U.S. students to gain cultural competency and learn medical Spanish and also medical English. So we are trying to do this bi-directionally. So basically, my dream in the future is to have both students going, to Colombia and Colombian students coming to the Bronx. But stay tuned. So the idea with this project is to engage U.S. faculty and so they, with the students, so they can submit a robust application. Also, many students they come here for observerships, but they have a lot of challenges and they don't get to know their mentors. Also, mentors struggle to provide strong letters of recommendations in a short period when they know the students. So the idea is to have a mentoring program between ICESI and Albert Einstein, at our infectious disease division through remote meetings and didactics as the step one. So that's phase one. This is why we are here. So we're going to start with remote online lectures on infectious diseases, both in English or Spanish, depending on who is presenting, with the idea of those that are motivated to learn Spanish or English or just practice a little bit and learn infectious diseases can come to our lecture and get all the benefits that it has. And then, in the near future, the idea is that if there's like motivated students that want to have some international mentors here or there, then we can try to arrange something to discuss career goals, etc. Phase two, as I said, is in progress, but the idea would be to have like a more physical, rotation at each site. So with this, I just want to stop. I don't want to take more time from Hendrik. Just want to say that Hendrik, it's going to start these lectures. I think he's the ideal person to do it because not only because he's excellent, he's one of our best fellows, but also because he's in both worlds. So Hendrik, for those that don't know Hendrik, so he's one of our infectious disease fellows, but he's doing he's training as part of his third year in Colombia. So he's right now in Cali. He's working closely with CDIM, which is an international infectious disease research institution, and he's also working at Fundación and with ICESI. So with no further delay, I'm just going to stop sharing and let Hendrik start.
Can you see my slides?
You do.
Yeah.
Great. All right. Thank you, Julian, for the introduction, and thank you for the invitation to speak as the first speaker for the IDEA project. As Julian mentioned, I am a postdoctoral fellow at the moment at Albert Einstein College of Medicine, and at the moment in Cali, Colombia, and we are conducting research here at CDIM in collaboration with ICESI and Fundación YDDD. Today, I will focus on arboviral diseases and dengue diagnostics. First, a bit of an overview. So arboviral disease epidemics emerged and re-emerged over the last 50 years. For example, there was an increase in birth prevalence of microcephaly associated with Zika virus in Latin America. There's the West Nile virus epidemic in the Americas that spread from the US down to the rest of the Americas. There was an emergence of chikungunya virus in East Africa before its global spread. And there's an ongoing dengue virus pandemic in the tropics and subtropics, including the Americas and Colombia. And recently there is the re-emergence of Oropouche virus in the Americas, to just name a few. The term arboviruses comes from arthropod-borne viruses. These are primarily transmitted to humans through bite of arthropods, meaning mosquitoes, ticks, biting midges. There are about 130 arboviruses known to cause human disease, In the Americas, the most important arboviruses are flaviviruses, including dengue, Zika, yellow fever, West Nile virus, and Powassan virus, among others. And togaviruses include the genus alphaviruses, and most notably chikungunya, but also Mayao virus and Eastern equine encephalitis virus, which has become a topic more recently in the United States. Gunya viruses also play a role, including Oropouche and the California encephalitis virus. In the following slides, I will touch on some of these arboviruses, not in detail, but more like a rapid fire review before focusing then on dengue. First, West Nile virus is transmitted by Culex mosquitoes. These do infect birds that are amplifying hosts and then transmitted to horses and to humans, which are dead end hosts. That means that humans and horses will not transmit the virus to mosquitoes due to viremia that is too low. On the right side, you see a map of the geographic distribution of West Nile virus over the years. So in yellow, you see the areas where it was detected in Africa in the 1930s before it spread to India in the 1950s, and then it spread in the 50s to 70s to Europe, to the Middle East, to Australia. And then in 1999, 2000, it spread really from the United States to the rest of the Americas. Besides mosquitoes, it can be transmitted through blood transfusions, organ transplantations, laboratory accidents, or from mother to baby vertical, although these are rare. The risk factors for severe disease of West Nile virus disease are age over 60, or comorbidities such as hypertension, diabetes, chronic kidney disease, immunosuppression. You should suspect West Nile virus in the patient who possesses fever after recent exposure to mosquitoes within 14 days. Fever occurs in 20 to 30% of patients with headaches, fatigue, myalgias. It can cause Guillain-Barré syndrome with a symmetrical ascending weakness, and in less than 1% of the cases, there can be West Nile virus neuroinvasive disease, which has, though, a 10% fatality. The spectrum includes acute flaccid myelitis with an asymmetrical limb weakness affecting the anterior horn cells, as well as meningitis and encephalitis. Diagnosis is via antibodies IgM in serum or CSF if there are neurological symptoms, or TPCR usually in immunocompromised patients, and there's no vaccine currently available. I included Eastern equine encephalitis, not because there's so many cases, but recently it has been in the news because there were cases detected in the northeast of the United States, 8 cases in 2024, and 8 of those were neuroinvasive, with one failed case also in Massachusetts, which has recently led to closing down parks, for example, because it is usually transmitted in swamps. The transmission also here needs an amplifying host, which is the bird, and is transmitted through Polysetas mosquitoes within the cycle. It needs a bridge vector, Coquilletidas, Aedes, or also Polyceta, that infect dead hosts. Horses and humans rarely can be transmitted through transplants. Symptoms include fever, headache, joint pain, but also seizures and coma. In the case of encephalitis, severe disease is present in less than 5%, with 30% case fatality and 50% have neurological sequelae. Diagnosis is via serum CSF or CSF IgM. It should be sent for confirmation with neutralizing antibodies to the state laboratory or the CDC. In immunocompromised patients, also a TPCR can be considered, but there's no vaccine available at the moment. treatment is supportive as for all the arboviruses, really. We shift gears to those arboviruses that primarily affect tropical and subtropical countries, including chikungunya, dengue, yellow fever, and Zika. This map of the WHO shows in blue where at least 3 of those arboviruses co-circulate, including the Americas, but also Africa and Southeastern Asia. The green zones, including China, some parts of the Middle East and Africa, show those areas where 2 of those co-circulate, and for example, Australia only sees dengue. Zika was first identified in Uganda in 1947 in monkeys and then 1952 in humans. And it spread through the Americas 2015 to 16 and was depicted a public health emergency of international concern due to the microcephaly cases, as you all know. It's transmitted through Aedes aegypti. Also, it can be transmitted vertically, sexually, in the laboratory, or through transfusions. It's mostly asymptomatic, but can cause rash, conjunctivitis, muscle aches, pains, headaches. It rarely presents with severe thrombocytopenia. Notably, it can have neurological consequences, Guillain-Barré syndrome as well, neuropathy, myelitis. As mentioned, during pregnancy, it can cause microcephaly, congenital malformations, miscarriages. There are no vaccines available at the moment. However, there are multiple vaccines in development at this point. Yellow fever has in the Americas 2 transmission cycles. There's a sylvatic cycle and an urban cycle. In the sylvatic cycle, the virus is transmitted between mostly Haemococcus mosquitoes and non-human primates, and in the urban cycle, such as in Cali, through Aedes aegypti and humans. In Africa, there's also a savanna cycle, which does not exist like this in the Americas. It's transmitted, as mentioned, through Aedes and Haemococcus mosquitoes. One case of perinatal transmission is documented. Symptoms include fever, chills, severe headaches, general body aches. As with the other arboviruses, severe disease can cause jaundice, bleeding, shock, and organ failure, transaminase elevation, and the mortality in these cases is 30 to 60%. Live vaccine is available, Stamaril Sanofi, which is usually required coming from an epidemic country. Chikungunya was first identified in Tanzania in 1952. Now it's spread to over 110 countries. In 2015, it was introduced in the Americas and is still available. Chikungunya is transmitted also by Aedes aegypti and Aedes albopictus. It has similar symptoms to other arboviruses, but very pronounced are significant swelling of the joints and joint pain. It can lead to chronic joint pain that might resemble rheumatoid. It can last for several months. A vaccine is available in the United States from an Austrian company. This is CHIK, and while it is FDA approved, it is not yet available in Colombia. Oropouche has been of more interest recently. However, it was detected already in 1955 in Trinidad and Tobago near the Oropouche River. There were cases, for example, around 2000, before 2000, in Brazil, in Colombia as well. However, this year, Brazil has seen 7,900 cases. That's the last update that I saw. And in Colombia, we are at the moment at 87 cases, although some figures vary here. Most of these cases are in the Amazon region, for the US Americans, that is in the south of Colombia, and has has mostly tropical rainforests, but also has been detected in Caquetá and Meta. Pucci is transmitted by biting midges, Polypoides, but also Pulex, Coquetida, and Aedes cerratus mosquitoes. It can be transmitted vertically, most likely. There was one fetal death confirmed and congenital abnormalities in Brazil. So there's 2 confirmed cases and 10 are under investigation at this point. The symptoms are similar to other arboviruses, really with fever, chills, headache. And for Pucci, there is no vaccine available currently. To simplify things, I will the rest of the presentation. So dengue is transmitted by Aedes aegypti and Aedes albopictus. In the Americas, this year we have over 11 million suspected dengue cases. Dengue presents symptomatically like the other arboviral infection. Eye pain is sometimes reported. Dengue has 4 distinct serotypes. A secondary infection with a different serotype than before is a risk factor for severe disease. A vaccine is available in Colombia. Very recently this year, Takeda's Qdenga became available. It is also available, for example, in Europe, in Asian countries, however, not in the United States, where it was not FDA approved. There we have Dengvaxia, which is not available here due to possibly worsening of disease in some studies. And a newer vaccine, Butantan, is a 1-dose vaccine which is promising, but it is not yet approved. In Colombia, there are fluctuating patterns with epidemic cycles approximately every 3 years. However, this trend has been interrupted since the last year. This year, there are about 250,000 probable dengue cases. This graph shows the so-called endemic channel. In this, the upper red line is showing the expected cases. So we can see that the points, the black dots above it, indicate that throughout this year, dengue cases were higher than expected, and recently, this month, they're decreasing. Dengue is classified by the WHO into dengue without warning signs, dengue with warning signs, and severe dengue. So probable dengue you can expect in a patient who lives in an endemic region, such as Valle del Cauca here in Colombia, in the state of Departamento, where Cali is located, or that traveled from such an endemic area, has fever and at least 2 of the symptoms, nausea, vomiting, rash, aches and pains. The tourniquet test, you can see already petechiae when you measure the blood pressure. Warning signs would require admission and strict observation. Those include abdominal pain, bursting abdominal pain, tenderness, vomiting, persistent vomiting, clinical fluid accumulation, mucosal bleeding, lethargy, hepatomegaly, an increase in hematocrit, and a decrease in thrombocytes. These symptoms can progress to severe disease, which is marked by severe plasma leakage leading to shock, fluid accumulation leading to respiratory distress, severe bleeding is a hallmark, and severe organ involvement, including the liver with transaminase elevation, but also confusion, heart and kidney can be affected. The Pan American Health Organization of the WHO recommends an integrated management strategy for dengue prevention and control. This multifaceted approach includes epidemiology, vector management, environmental factors, improving patient care, also vaccines, and integrating the community and evaluation. It also does include the laboratory aspect, and on this we will focus for the rest of the presentation. Dengue diagnostic is complex, and it usually starts with viremia, which can be detected by RT-PCR before onset of symptoms after a bite of the mosquito. Viremia is detectable usually until in the first week, but increases sharply after the fifth day. One antigen, non-structural antigen 1 of dengue is detectable also in the first days, but then decreases. IgM, usually immunoglobulin M, increases sharply at day 5 and after, and then stays elevated for week number 1. IgG increases about day 10 and then will stay detected. It's important to note that the antibody response differs between the primary infection and the secondary infection. In the primary infection, there's a robust IgM and IgG response. However, in the secondary infection, so when we get infected serotype, there's a robust IgG response, but the IgG response is sometimes attenuated, and so can always be detectable in secondary infection. Of note, in Cali, Colombia, about 90% of the population already had dengue, and so here you will see a lot of secondary infections. This is the dengue diagnostic algorithm of the Pan American WHO. It does recommend dengue diagnostic based on the time of symptom onset. If symptom onset was less than 5 days ago, then RT-PCR is recommended, or NS1 ELISA. If it's negative, then that likely means a negative case. However, the caveat here, of course, is that sometimes it might be already undetectable. The first 5 days sensitivity is good, though. In case of a positive result, this algorithm suggests that dengue is confirmed and that serotyping should be done with RT-PCR if possible. After day 5, this algorithm recommends dengue virus ELISA. If it's negative, then it is categorized as a negative case. As mentioned, this has the caveat that sometimes in secondary infections we have an attenuated response and it might not be detectable. Positive, then the IgM, the difference be that there was a recent flavivirus infection. How it might be that it was in the recent months. So we always have to see it in the clinical context and take the symptoms into account. In a negative IgM test, as mentioned, due to secondary infections and a attenuated response, it can sometimes still be a dengue probable disease, but it also could be a negative case. So the bottom line here is that dengue diagnostic is complex and it is imperfect. So there's no perfect reference standard for the diagnosis of dengue. In the rest of the presentation, I will talk about our project that we're realizing with CDI here in Cali, Colombia, as well as ICESI University and Fundación Valladolid, and our partners at Yale and at Einstein. It's about the evaluation of nucleic acid amplification testing in saliva and urine for dengue diagnosis in Colombia. Our study team includes here in Colombia Valladolid and ICESI on the left side, of CDI on the right side, and our international The institution collaborators are Albert Koch from Yale, Hussein Cesarabia, the director of CBDM, and Johanna Bailey of Einstein. Dengue is diagnosed currently in blood. This table shows an overview of a study among 250 children in Cambodia, where dengue virus RT-PCR was compared in blood, urine, and saliva. In blood, RT-PCR has a high validity in the first 3 days, sensitivity 89 to 100%, and specificity over 97%. However, it decreases after the first week, and it's an invasive diagnostic tool. In urine, sensitivity peaks at 55% at about a week. However, it was superior to blood after the first week to detect dengue. RT-PCR in saliva has relatively higher sensitivity in the first 5 days, about 80%. However, it decreases in the first week. Its advantage is that it's less invasive and can detect infections early. However, the sensitivity decreases after the first 3 days. In this study, the combined RT-PCR sensitivity in saliva and urine was in the first 5 days, 75 to 83%, and in the second, or in 1 week, it was about 68%, and in the second week, it then decreased to 46%. So in this study, we're asking ourselves, what is the validity of RT-PCR in saliva and urine as alternative diagnostic method to the reference standard in blood for the detection of dengue? The project aims to validate less invasive diagnostic methods for dengue that could be used in different stages of the disease. We want to provide information about the impact of demographic, clinical, and laboratory factors on the validity of dengue virus RT-PCR in saliva and urine in Cali, Colombia, and we aim to strengthen molecular diagnostic capacities. Objectives are thus to determine the sensitivity and specificity of the composite and independent dengue virus RT-PCR in urine and saliva for the diagnosis of dengue after the onset of fever over a 2-week period, and to explore the association of demographic, clinical, and laboratory factors with the sensitivity and specificity of dengue virus RT-PCR in urine and saliva. Over a period from September 2024 to August 2025, following RB approval, we plan to include 90 participants, those 45 suspected cases with dengue and 45 suspected cases without dengue. We will recruit patients initially at Fundación Valdelili Hospital, and are considering as well also other health centers here in Cali. We will follow the patients over 2 weeks. Visit 2 will be at day 6 ±2, and visit 3 will be at 2 weeks ±2 days. We will follow up the patients at Fundación Valdelili Hospital or CDM in this alternative also during home visits. The samples will be transported for processing to CDE. We will include patients of any sex between 7 and 90 years old, hospitalized and outpatients. It includes also patients that present to the emergency department. The suspected cases with dengue will comply with the definition of dengue symptoms of the National Institute of Health here in Colombia, which bases this criteria in WHO. Also for screening, we will identify patients initially with NS1 antigen or IgM rapid test, which is positive in suspected cases with dengue, and in those suspected cases without dengue, we will include febrile patients with another established diagnosis, and these have to be negative for the screening tests. We will exclude participants who cannot provide at least one blood sample and either a urine sample or a saliva sample, and those with cognitive or physical impairment who cannot provide the required information. We will collect demographic, clinical, and laboratory data initially. Those include age, sex, ethnicity, socioeconomic status, but also comorbidities and medication, previous dengue infection, and laboratory values include hemoglobin, thrombocytes, liver and kidney values. We will assess the symptoms and the severity of the patients. We will do a questionnaire at every visit, and we will collect blood, urine, and saliva samples at all 3 visits. During the first visit, we will first review eligibility criteria, then take informed consent and ask them for minors. We will apply the demographic and clinical questionnaire and then proceed with sample collection, including blood, urine, and saliva. During the visit at 2 and 3, we will again apply clinical questionnaire and then collect blood, urine, and saliva samples. And the remnants will be stored in a biobank. We will recruit, as mentioned, 45 participants with dengue symptoms of suspected dengue cases and 45 participants with an alternative febrile illness. Those could be bacteremia, for example, influenza, or other conditions. We will match these patients by sex and age category. The reference standard that we will use is RT-PCR dengue in blood, in serum, and IgM, IgG capture ELISA. Those have to be positive for our dengue cases and negative for those that are categorized as controls. We will repeat IgM, IgG ELISA at day 14 at the last visit in case of indeterminate results. And the IgG that we are using is Panbio high titer IgG with a cutoff calibrator, so as to detect acute dengue cases but not past dengue cases positive for IgG. The index test, so the test that we want to assess our saliva and urine. As mentioned, we will collect them during all 3 visits. Also, blood will be collected at every visit. And the transportation occurs at 2 to 8 degrees Celsius. It will be stored at CDE at minus 80 degrees Celsius, and we'll process the sample at CDE in the BSL-2 laboratory. We will conduct a sensitivity and specificity calculation. We will also consider a latent class analysis, which takes into account that the reference standard for dengue is imperfect. We will build a multivariable logistic regression model to explore the factors of heterogeneity. We will use EasyRADCAP and RADCAP as a data management tool. For quality control, we will contract external monitoring and do a verification of 10% of the source data. For reporting, we will use the START guidelines from 2015. The expected outcomes of the study are the determination of diagnostic validity of dengue virus at RT-PCR in saliva and urine samples after fever onset, during a follow-up of 2 weeks, as alternate diagnostic method of serum. We will determine clinical, demographic, and laboratory factors potentially associated with the validity of urine and saliva tests in Cali, Colombia. We also will strengthen local capacity to perform molecular dengue testing in Cali, and we aim to promote educational and research opportunities for students through a multidisciplinary and international collaboration. in summary, there is a reemergence of arboviral diseases over the last 50 years, including dengue and Oropouche virus. Chikungunya, Zika, and Oropouche are likely underreported because they often get classified as dengue cases or not being tested for. The reference standard for dengue is imperfect, and IgG, IgM response depends on primary versus secondary infection. Dengue virus RT-PCR shows varying sensitivity and specificity over time after fever onset. I would like to acknowledge our colleagues from Fundación Valle Lili, Alvaro Martinez, Fernando Rosso, Diana Rueda, but also the other collaborators at CDM, Alejandro Vargas, Dean Alexander, Nancy Saravia, and other co-investigators. At Yale School of Public Health, Albert Koh, and at our Einstein College of Medicine, Johanna Daly, co-investigator, but also Eileen McGinn from the Master's Clinical Research in Exam. Jurovsky, the Director of Infectious Diseases at Einstein. These are the resources that I used. Thank you very much. We would like to include a student in our project, and so I think it's a good opportunity to ask if you are interested to join the study. Then you can shoot me an email here with my email address, and I'm not sure how many people use Pedestal, but I thought I'd just put it here. So thank you very much, and please let me know if you have any questions.
Thank you, Hendrik. That was amazing. That's great. So we have a few minutes for questions. I see actually my voice is translating, so that's good. Great. So we have questions. You can put the questions in the chat in either Spanish or English. I'll be happy to translate. I guess I can start, Hendrik. So what is that? Let's say, like the results are very positive, you're very happy with your study. So what do you think is going to be the niche for testing? Let's say if this, in the future becomes something like that is like commercially available. What do you think would be the niche, given the non-invasive?
So first, in Colombia, RT-PCR is quite, RT-PCR is expensive, right? And so I think the first step is to really build the capacity here at CDM to do these kinds of studies and to use RT-PCR. Why are we looking also at urine and saliva? So it could help us to detect dengue virus over different stages of the disease. So urine, for example, stays positive longer than blood and saliva more in the beginning. So in the future, it could be integrated into diagnostic algorithms. And the next stage, if we have good results, would be to scale it. So one application would be kind of the clinical application. Another possible application is a public health application. It could inform local dengue transmission programs. So we would discuss further with the Secretaría de Salud, the Department of Health, for example, to see if this approach can be integrated into their transmission programs, and if this could be useful for them. In the chat,
hello, I have a question in your chat, please.
Right. Hello. I see the question. So the question is if we can manage to have rapid testing for serotypes that could help in the treatment diagnostic of dengue, right, and also for epidemiological purposes. And so we are assessing also the serotypes 1 to 4. However, the test RT-PCR is less so a rapid test because it needs, it needs to be sent. Rapid test usually at the moment, NS1 antigen and IgM. At the moment, I don't know a rapid test that can detect all the serotypes. I think if this could be developed, it might be very interesting to stratify disease. The other, here in Colombia, at this point, all 4 serotypes are circulating. At this point, I don't know about any rapid test that integrates serotype testing. But also you could also give us some interesting information about the serotypes that circulate. Sure, that answers the question.
Yes, thank you. Can you hear me?
Yes, we can hear you. Yes.
Okay. Hendrik, I don't know if you mentioned this before, but what about the other arboviruses that might be circulating in Colombia? Have you anticipated how it will be the reaction in the technique you're using, or you have discarded that it will amplify because it's very specific?
That's a very good question. So at this point, we expect less circulation of Zika and chikungunya, but as I mentioned, often these get misdiagnosed as dengue, and so I think it would be very valuable to find out if there, is Zika and chikungunya circulating. We actually do have a multiplex PCR that also can detect Zika and chikungunya, and we will screen for alternative diseases, right? Not only bacteremia, etc., but also for Zika and chikungunya. So we might get interesting information about that as well. And yeah, that's really something that it would be an interesting question.
I think there's a question. Thank you, Beatriz. So I think there's a question from Natalia Moreno that is it's similar. So it says, I'm reading in Spanish and then in English. ¿Qué tan frecuente es tener pruebas falsas positivas en dengue debido a otros arbovirus? Y si esto, ¿cómo se va a evaluar en el estudio? So how frequent it is to have false positive dengue tests due to other arboviruses, and if this is going to be evaluated in this study? Which I don't know if you already kind of answered.
Yeah, so especially in IgM and IgG, it is possible to have false positive, false negatives. However, the exact numbers, are, to my knowledge, not, known here. How many of those are falsely positive, falsely negative? RT-PCR is very specific for the dengue virus, and we expect less falsely positive results here. Yeah. So I think, measuring also for the most common ones like Zika and chikungunya is something, which is of value. So we have this multiplex PCR that might give us some clues. Yeah.
Hendrik, any comments on the, I don't know if you have the answer to this question, but on the rollout of the vaccine in Cali or in Colombia? What's the status of?
So the Takeda vaccine Qdenga, which is a tetravalent dengue vaccine, 2 shots, works best for dengue virus 1 and 2 and less so for 3 and 4. it was approved last year by INVIMA, which is the agency here, and it became available over really the last months. And so, yes, it is available here in Cali in vaccine centers. The biggest barrier with this is the price. It's about 720,000 pesos, which is $200, which is a lot of money here. And so I think this is likely the major burden in the rollout. Another vaccine is not currently available. Butantan, as I mentioned, is a one-dose tetravalent vaccine with good results in Brazil, but this one is not yet available. It might be an interesting option in the future. Yeah.
Thank you. Is there any other questions o otras preguntas? Okay, that was great. So I put in the chat a link for the attendance. You can please click on that link and just fill out the information. It's pretty straightforward. Should be a couple questions, and I just want to thank everyone that came to this lecture. I think this is very exciting. I have to say, the next lecture is going to be presented by ICESI on Oropuche, so kind of like a related lecture, kind of like to continue with tropical infectious diseases. I will be sending the date very soon, and thank you everyone for joining. This was great.
Thank you very much, Julian and Hendrik. Great, really, really nice to have started this idea. And thank you for all the participation, for all the assistance.
Okay, have a nice weekend, everyone.
Bye-bye. Have a good weekend.
Bye. You too.